Shwetal ma'am, it's 3 p.m. now. Shall I begin with the session?
We are waiting for the expert faculty to join. Just give me a 1 minute more.
Okay, ma'am. Sure.
I have sent her a message. Dr. Riddhi will join soon.
Okay, ma'am. Sure.
Krunal? Dr. Krunal?
Yes, ma'am. Yes, ma'am.
Miss, why didn't you turn up at Surat? What happened?
Ma'am, I had a emergency at hospital and there was few functions at my home.
Okay.
So I could not make it to Surat.
Okay.
And
We
initially
missed you.
I had, yeah, ma'am. Initially I was given that it was be on Sunday. So the functions I had kept on Saturday at the home. Then the program shifted. It became on Saturday.
Oh, but you would
But
have joined on Sunday also. We were there.
yeah, that so I thought because I could not make on panel discussion, so I thought it would not look good to come on the next day.
Oh, you would have told me.
Because then it was appointed as on Saturday, and you don't come on Saturday and come on Sunday, it won't look good.
No, એવું કશું નતું. કઈ નહીં. Next time I'll take care of that part also.
Okay.
ખાલી કીધું હોત તો તમારું બદલી કાઢ્યું હોત Sunday.
પણ આ વખતે બહુ બધા ચેન્જ થયા અને પછી આશીષ સર નું આવ્યું ને બધું મેં એટલે કીધું વચ્ચે પડાય એવું નથી. હવે જે સેટલ થયું હોય એને શાંતિથી પૂરું કરીએ.
Okay. So now we have Dr. Riddhi with us. Momita?
Yes, ma'am.
We can start.
Okay, ma'am. A very good afternoon and warm welcome to all the dignitaries present here. I am Momita from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the National Neonatology Foundation. And the focus of today's session is case presentation hyperinsulinemic hypoglycemia. So now, without any much delay, let's begin today's session, for which I would like to invite Dr. Shwetal Bhatt ma'am to take over further. Over to you, ma'am.
Thank you, thank you, Momita. So we are here again back for the neonatal Pathshala, and we have an interesting case discussion on hypoglycemia in neonatal period. We have an expert faculty from endocrinology. So I will like to request Dr. Krunal to introduce Dr. Riddhi, and Dr. Divya will then present a case.
Okay. Dr. Riddhi is a young dynamic endocrinologist from Vadodara, and she will it will be a very fruitful discussion. Dr. Divya Waghela will start the case presentation, and the expert Dr. Riddhi will help across the discussions and guide through the discussions. So without wasting much time, we'll start the discussion. Dr. Divya, you can start your presentation. Dr. Divya, you unmute yourself.
Good afternoon, everyone. Myself, Dr. Divya Waghela, third year resident, Medical College, Baroda. I'm presenting a case on hypoglycemia, neonatal hypoglycemia under guidance of Dr. Shweta ma'am and Dr. Jay sir. Patient information: baby of XYZ with a male child born out of non-consanguine marriage, born at the 13th September 2024 at the 4:46 p.m. born by LSCS, and patient on birth weight, it is a 2.2 kg with a 38 plus 2 week with SFD child, resident at the Manejas Ivanpura, Vadodara. Mother and father education: mother at the 7th standard with the father education 9th standard. Family per monthly income 15,000 with belonging to lower middle class. Antenatal history: maternal age is 32 year with the age at marriage 21 year of age. with the gestation gravida 2, para 2, abortion 0, live 1. Gravida 1, which is a female child, full term normal vaginal delivery, and presently she is 10 years of age, with currently patient uh, m- current gravida LMP was 20 December 2022 23 with expected date of delivery 27 September 2024. Pregnancy detected by urine pregnancy test at 4th week of amenorrhea and confirmed by first antenatal USG at 6 week of gestation age. First antenatal USG take at the 20 week of gestation age with the folic acid supplement started with a patient not having any complaint of vomiting, fever with rash, any exposure to teratogenic drug with radiation exposure or not any other medication. Second trimester anomaly scan done at the 20 week and 24 week which was on within the normal limit. Fetal movement perceived by mother with fifth month of uh, gestation age and folic acid calcium supplement started. Patient taken 2 doses of fetal toxin with 1 month apart. On third trimester, 2 USG done, which is 7 month and 9 month of pregnancy. 7 month pregnancy was normal and no any maternal history of fever, leaking per vaginum, UTI, fever with rash, bleeding per vaginum, convulsion, blurring of vision. Uh, natal, uh, natal history. Mother developed labor pain at 13 September 2024 at 4 p.m. and for similar complaint patient present to SSG hospital. At SSC Hospital, portable CTG revealed fetal distress with tachycardia of 180 beats per minute with the USC suggestive of mild oligohydramnion with AFI 4.2. Maternal BP on that time it is 182 by 1110. So with considering pre-eclampsia, emergency LSCS was taken for fetal distress with the mother history of pre-eclampsia. Date of birth that is 13 September 2024 and birth time was 4:46 p.m. by LSCS vertex presenter with clear lightweight with birth weight 2200 grams. Patient cry immediately after birth with on-table breastfeeding was established and routine care was done. Patient is stable, so patient is shifted to postnatal ward. Patient active, alert, and meconium and urine pass within 24 hours of birth with taking breastfeeding well. On a second day of life, patient develops sign of hypoglycemia in form of difficulty in feeding and lethargy. For similar reason, patient is shifted to NICU. RBS was taken. That time of RBS has 39 milligram per deciliter. Considering symptomatic hypoglycemia, 2 ml per kg 10D bolus is given, and patient was started GDR6. On that time, patient is euthermic with the heart rate 130 per minute, respiratory rate 32 per minute, SpO2 96 on pre-ductal, 95 on post-ductal, CFT less than 3 seconds with no any sign of shock. On RBS 39 milligram per deciliter. Considering a hypoglycemia, we signed septic string with HB 18.5, W is 6,800, platelet 1.17 lakh, CRP 13, with the hematocrit 56.9 with lab RBS 35. Patient RBS monitored every hourly with the patient develop episode of hypoglycemia in same day. RBS 35 milligram per deciliter. So patient is escalated to GDR8. And on third day of life, that is 16/9/2024, patient on GDR8 and main feed and room air. And patient similar day, patient developed hypoglycemic conversion in form of cyclic movement of all four limbs associated with desaturation recorded. Recorded RBS was that time is 38 milligram per deciliter. Vital of patient have a hypoglycemic conversion and that time of vital is a patient on euthermic heart rate 142 per minute, SpO2 86 on room air with RBS 38 milligram per deciliter. Considering hypoglycemic conversion, GDL escalate to 10 with the main feed. Repeat septic screen is sent, which is negative. Considering rule out the other cause of conversion, we send the ionized calcium, which is 1.2, Rf sodium 134, potassium 5.5, urea 15, create 0.6 with the USG head, which is normal, and CSF was done. It's just sugar 51, CSF protein 56, with the CSF fluid examination shows cell less than 10. On similar day, at 76 hours of life, patient developed tachycardia with heart rate 226 beats per minute. For to to check out the tachycardia, we do ECG. ECG suggestive of narrow QRS complex absent P wave. Considering SVT, adenosine given, 3 doses of adenosine given, patient on patient respond to adenosine, and after consecutive 3 doses, patient heart rate normalized to 145 beats per minute. To rule out the other congenital heart disease and structural anomaly of heart, we do 2D echo, which is normal. Patient have a 2 episode of hypoglycemia and require in a similar day, that is a 16/9/2024. Critical example, that is the insulin 3.2 micro unit per minute, cortisol 13.2, which range 5 to 25, lab RBS 35, serum beta hydroxybutyrate 0.18, thyroid report, serum thyroxine 9.4, T3 level less than 1, T4 less than 1.6, septic scan is 16.9, WBC count 9,300, platelet count 38,000. Considering septic, first line antibiotic was started, and at that time patient have a detect insulin at the concurrent lab RBS 35, insulin was recordable, that is the 3.2 micro unit per ml with the low serum beta hydroxybutyrate. With the continuous RBS monitoring, with the patient maintain blood glucose level more than 15 milligram per deciliter, that is we taper the GDR gradually by GDR 10 on 18 and 19 day of life. We are gradual GDR 8 to 6 with the man fit. On the 19th September, patient developed jaundice, which ranged between the phototherapy and exchange. So patient require SSPT for 24 hours. On next day, patient out of the phototherapy range, so phototherapy was omitted. On 20th September 2018, 8 day of life, patient developed episode of hypoglycemia, GDR 8, which required GDR 8, and considering persistent hypoglycemia, hydrocortisone was started at a 10 milligram per kg per day and kept in maintenance dose. To rule out the other cause of hypoglycemia, we send a ammonia level, reduce urine for reducing substance. To rule out hyperammonemia, hyperinsulinemic syndrome, ammonia is 144, which is normal, reducing substance for galactosemia, glucose 6-phosphate, fructose 6-phosphate deficiency, which was negative. In considering a secondary cause of inborn error of metabolism, serum lactate was sent, which is 3.4, which is normal. ABG, which not suggestive of metabolic acidosis, ammonia was normal, and urine for ketone bodies also negative. So inborn error of metabolism of rule out. On patient kept on 3 day for maintenance therapy on hydrocortisone, but still patient not respond to hydrocortisone. On 23 September 2024, 11th day of life, patient on GDR 8 with a minimal enteral fluid developed episode of hypoglycemia and with RBS 33 milligram per deciliter. So we again escalate the GDR to 10 and consider refractory hypoglycemia, which is not respond to hydrocortisone. We add octreotide at the 5 microgram kg per day subcutaneously. On 24th, on next day of life, patient again develop hypoglycemia. So GDR escalate from 10 to 12, and for that day, we also increase the octreotide dose from 5 to 10 micro per kg per day. There is a continuous RBS monitoring with the patient kept on a octreotide maintenance therapy at 10 microgram per kg per day. We are able to taper the GDR gradually from 12 to GDR 6 at 27th 2024, and then taper the GDR 6 to GDR 4 and gradually increase in feet And at the day of 29 September 2024, 70 day of life, patient on full feed. We send critical sample when patient is required GDR12 for maintain euglycemia, require hydrocortisone octreotide treatment, and during hypoglycemia, concurrent RBS 32 milligram per deciliter with a detectable serum insulin, that is a 3.2 microunit per ml, serum beta hydroxybutyrate 0.80 with a serum cortisol 13.2, which favor the diagnosis toward hyperinsulinemic hypoglycemia. Plan the on further evaluation, plan to send genetic worker for further evaluation of or rule out the congenital hyperinsulinemic hypoglycemia or genetic associated any other genetic association. This table show the diagnostic criteria for hyperinsulinemic hypoglycemia, which show the any detectable insulin, detectable C peptide, free fatty acid lower side or suppress, ketone body lower side or suppress, ammonemia which is normal or can be rise in hyperammonemia, hyperinsulinemia syndrome. Cortisol, which is raised generally uh, because of the counter regulatory hormone, that is a cortisol or growth hormone. Other is amino acid, urine organic acid, which is normal, may be raised in inborn error of metabolism. Additional information when diagnosed with hyperinsulinemic hypoglycemia, that is glucose infusion rate. GDR require more than 8 milligram per kg per minute to achieve euglycemia, with patient respond to IV glucagon more than 1.5 millimole per liter, or patient requires subcutaneous octreotide treatment. This picture show the different causes of hypoglycemia. Hyperinsulinemia, which is the most common cause of the hypoglycemia in neonatal age, which further categorized to transient and congenital. Transient, infant of diabetic mother. Secondary cause like infant of diabetic mother, perinatal asphyxia, RH incompatibility, IUGR patient with other congenital cause like the ABCC8, KCN, Z11C, glucokinase, GDH, HADH, HMN, 4A, HNF41A, UCP2, SLC. These are its gene which is the most probably encountered in congenital hyperinsulinemic hypoglycemia. Other cause is the postprandial hyperinsulinemic hypoglycemia, insulinemia, and exercise-induced hyperinsulinemic hypoglycemia. Picture others show the many other cause like in glucogen disorder with the glycogen storage disorder, glucose transport defect with the fatty acid oxidation defect. All other show that the cause of hypoglycemic hypoglycemia in human, but most common cause is the hyperinsulinemic hypoglycemia, which may be transient, probable prolonged, or maybe uh, permanent. Transient hyperinsulinemic hypoglycemia most probably require treatment for few day to few week, and which respond to GDR and which is resolve and normal glucose within 1 week, and a prolonged prolonged hyperinsulinemic hypoglycemia may be present in SFD child or infant diabetic mother. Other cause of congenital permanent hyperinsulinemic hypoglycemia may be require more than 6 months of octreotide or other medication treatment for patient keep the mention patient in euglycemia. This picture show the medication which used in a hyperinsulinemic hypoglycemia. First line treatment, which is the first standard drug, that is the dioxide, 5 to 20 milligram per kg per day. This drug made this drug bind to Suri subunit of intake KATP
I
channel.
think Riddhi, we can have a discussion now.
Yes.
Ah,
Now
yes.
I think we can more discuss on the case part.
Yes.
So Divya, I just want to ask, what was the examination pointers that favors development of this refractory form of hypoglycemia in this child?
Ma'am, on examination, patient is a full-term 38-weeker SFD child with a patient have a uh, uh, with no any other cause, including risk
Okay.
factor SFD,
Okay.
and patient on the not patient initially we are starting on GDR6, which not patient not respond to GDR6, and we are gradually escalate to GDR10, and patient also
Okay.
require
So there was no any dysmorphism or any features that were favoring the permanent form of hypoglycemia in this child,
no ma'am,
right?
patient have no any
Okay.
dysmorphism or
Have you
syndromic
missed
feature.
anything in terms of negative history asking, especially in this child?
Yes, ma'am. Based on patient have a long required GDR8,
No, no,
maybe
no. I am asking about the any specific history you will ask each and every patient where you made the diagnosis of hyperinsulinemic hypoglycemia. You will ask the history of that point in mother, especially.
if mother have a on a infant of diabetic or mother taking
Yes.
beta blocker
So
or
whether
turkey.
OGTT was done twice. So because current recommendation of the American Society of Obstetric and Gynecology advised we do the OGTT, that is oral glucose tolerance test,
Yes, ma'am.
first trimester and second last third trimester.
Yes,
So
ma'am.
whether it was done or not. Because
Ma'am,
many of the times, mild cases of the GDM, that is gestational diabetes mellitus, may don't have any symptom of hyperglycemia.
ma'am, OGTT was not done, but the random blood and fasting blood sugar was done, which is normal.
Okay.
Or
Any HbA1c was done or not?
no, ma'am, HB1C not done.
Okay.
Patient not any medication like propanol.
Divya, this is our book case.
Yes, ma'am.
Our book case always the HbA1c is done.
Okay.
Huh?
And second thing, have you find any cause for the this intrauterine growth restriction? Why
Ma'am,
child was IUGR?
patient on ma'am up to 7 months of pregnancy, patient all antenatal USG was normal. On 9 month, when patient is come for the labor pain, on that time CTG and USG was done. We suggest you of the mild oligohydramnion with the fetal distress.
Okay. So looks like asymmetrical form of IUGR, not the
Yes, ma'am.
symmetrical ones. Okay. Second thing, you have told ki on third day of life, first episode, the child developed hypoglycemia on 38 hour of life.
Yes, ma'am.
And next, there are in between two episodes were also there. But on third day of life, child through the symptomatic hypoglycemia, that is in form of seizure. And then you have escalated the dose of GDR. So what were the sugar readings in between? Because you were monitoring the sugars every hourly, na?
Yes, ma'am.
So what was the sugar value?
Ma'am, a sugar level more than 50.
Sugar level was maintained more than 50 on the
Yes,
GDR of 6.
ma'am. Maintain on GDR6.
Okay. Okay. And second thing, okay. And then why you have given hydrocortisone in this child? I'm not able to understand.
Ma'am, patient on the we escalate up to GDR12, and according on the when patient develop hypoglycemic conversion, we repeat the septic screen, and the antibiotic was introduced, and considering sepsis induced hypoglycemia, we introduce the antibiotic. Still, patient have a develop hypoglycemia and which requires GDR12, which is not.
So before giving hydrocortisone, you did critical sample.
Yes,
Am I right?
yes,
You
ma'am.
did critical sample and that was suggestive of cortisol value that is appropriate response. That was 13.2 microgram per deciliter.
Yes,
Okay.
ma'am. Yes, ma'am.
So I just want to deliver one message here ki if you did critical sample
Yes, ma'am.
and your cortisol value is appropriate for the level of sugar, there is no need to give hydrocortisone extra because your body is already producing so much amount of steroids
Yes, ma'am.
to adapt that low level of the sugar. but
Yes,
still it is not responding, it means there is another cause of the hypoglycemia. Either it can be hyperinsulinism or other metabolic ones. So this is not cortisol deficiency. Second, one thing. Second thing, so the clear-cut pointers to hyperinsulinemic hypoglycemia, if we start from the onset, so this child was full-term IUGR baby,
yes,
developed hypoglycemia very early at 38 hours of life. Initial 38 hours child was asymptomatic. And second thing, rapid escalation of GDR. There must be in between episodes of hypoglycemia, asymptomatic hypoglycemia must be there. So rapid escalation of GDR within 24 to 48 hours up to 10, still child was not responding to our routine management. And third thing is your critical sample suggestive of non-ketotic hypoglycemia. So only two differential to non-ketotic hypoglycemia at this age is, one is galactosemia and second is hyperinsulinism. Galactosemia onset is too early because we see the galactosemia after 72 to 72 hours, after third day of life, once the feeding is fully established and lactose intolerance develops. Okay. So these were the pointers that were suggestive of hyperinsulinemic hypoglycemia. And definitely you should start octreotide trial first. And if possible, diazoxide nowadays freely available. So you can start diazoxide also, rather giving hydrocortisone. Otherwise, case was good. And the third thing I want to ask, why T3, T4 were low in this case? Any clue for that?
ma'am,
So
maybe
this is simple physiology. Just you have to answer me. This is not pathological. Is this central hypothyroidism?
yes, ma'am.
Yes.
Yes, ma'am.
Central hypothyroidism. So baby was stressed, definitely,
Yes,
because baby had gone through too much of hypoglycemic episode and so much of neonatal stress. So that's why total T3, T4 can be low in this age. So definitely you should repeat the thyroid function test once the baby recovers, at least after 3 weeks of life, to rule out this is not central hypo. This must not be central hypothyroidism, but we should repeat. Okay. So
Yes.
that you can do. And another thing, now we can start like diazoxide is freely available. So better to start diazoxide because here you did everything from cardiac part. If there is history of tachycardia and you thought of that SVT, where we think twice before giving diazoxide, but definitely 2D echo was normal and child's cardiac function was normal. So diazoxide can be the first choice of drug before octreotide. Okay. And one thing I want to ask, at what GDR you want to, all this GDR were given from peripheral line only, or you did IV insert, sorry, central
Ma'am,
insert?
central line, UVC, catheter.
Okay. So what do you think? What is the cause of hypoglycemia in this child? Is it transient permanent variety or is it like potassium ATP channel defect?
Ma'am, patient full-term IUGR to most probably cause transient variety of hyperinsulinemic hypoglycemia, which is most common cause.
Yes, so this looks like transient variety. And how much time it will take to improve hyperinsulinemia, especially in IUGR babies?
Ma'am, up to week to month, ma'am.
Okay. Exit duration?
Ma'am,
So minimum 4 to 6 weeks and maximum it can persist up to 3 months. After that, it will resolve on itself. So till that time, we have to support something like octreotide. We have to continue, or diazoxide can be the option. And also parent should be educated about the home monitoring of the sugar as well as home correction of hypoglycemia to prevent any emergency.
yes, ma'am.
Any question do you have?
No, ma'am.
Okay. So now tell me the simple approach of any case of neonatal hypoglycemia, starting from where do you act? Matlab, where do you start investigating? Because we are seeing so many patients in our NICU having hypoglycemia. So where
Ma'am,
do you think that this is pathological form of hypoglycemia where you have to work up for hypoglycemia?
ma'am, patient initially we a patient which is a high patient who high risk patient like I- ID infant of diabetic mother with IUGR baby patient should be screened for the hypoglycemia, and if patient have a hypoglycemia develop, that is the hypoglycemia for asymptomatic blood glucose level less than 40 and patient have asymptomatic hypoglycemia, we should
So for
start.
any hours of life, you will consider blood glucose of 40 as a cutoff for hypoglycemia?
Uh,
Or it
ma'am,
is different for different age group?
ma'am, because of initially patient fetus blood sugar supply by the maternal side, after the cutting of the umbilical cord, patient cut off of the blood sugar level, so transient hypoglycemia may be developed in a newborn,
Very
which
good.
is regulated by newborn glycogenolysis ketone body synthesis process, which may be narrowed up to 30 milligram per deciliter within 1 hour, which progressively increase to 3 to 4 hours and maintain 66 to 70 milligram per deciliter within 3 to 4 hours of life.
Okay. So it's, you have to remember like 25, 40, 50 and 60. 25 for first 4 hours,
Yes,
50 for 4 hours to 12 hours, 60 for 12 hours to, 25, 40, 50. 50 is 12 hours to 24 hours. And after 24 hours, it is same for each and every age group. So it should be the cutoff of 60. So after 24 hour, cutoff is 60. And this is called operational threshold. This is not exact cutoff for hypoglycemia.
yes,
So
ma'am.
if any baby presenting with the symptoms that excluding of the other metabolic abnormality like hyponatremia, hypocalcemia, hypokalemia, or even sepsis, and your blood sugar is in the borderline range, then you have to consider this as hypoglycemia. These are just operational cutoff for those baby who don't have symptom. Okay, so remember 25, 40, 50 and 60.
Yes, ma'am.
Okay. So if the hypoglycemia in first 48 hours is considered physiological because baby is trying to adapt in extrauterine environment, and that is from it detached, baby is now detached from mother. So baby has to maintain his or her own sugar level. Okay.
Yes.
So initial 48 hours, if the hypoglycemia is mild, requiring mild JDR of 4 to 6 is considered physiological. If the onset of hypoglycemia after 48 hours, or if hypoglycemia persists beyond 48 to 72 hours, or if there is escalating dose of GDR to maintain the sugar level, so then it is considered pathological hypoglycemia, and then we have to worry and we have to work up. Okay. So now how will you approach the case of any case of hypoglycemia?
Ma'am, after 48 hours, if patient have a symptomatic hypoglycemia, we give 2 ml per kg of body weight, 2 ml per kg body weight 10D bolus, followed by we are starting GDR 6 for that patient. If patient have a
This is you are telling about the management part. Tell me about approach, investigation. How will you investigate?
yes,
So now you are sure that this is pathological hypoglycemia. You have excluded sepsis and everything. Those are the routine causes of hypoglycemia. Now how will you approach?
ma'am, we
How
send
will
the
you do the investigation?
ma'am, we send the first lab RBS for a confirmation of the sugar level. Then septic screen. Septic screen can be lead to hypoglycemia. Other cause is the septic screen. Uh, patient have a maybe have a CSF infection. it may be cause hypoglycemia. So septicemia should be ruled out. And other inborn error of metabolism, that is the serum ammonia level and serum lactate level. Other cause is a urinary ketone body or blood serum ketone body.
So your first investigation in case of hypoglycemia is to send lab sugar, that is the critical sample, to confirm it is with the lab sugar value, whether it is actual hypoglycemia or not. Because many of the times our glucometers are recording low sugar value as wrong, because glucometers are meant for high sugar, that are not for low sugar. Okay, so definitely we have to confirm it with the lab sugar. And then first critical sample you have to send is ketone. Okay.
Ketone
So
body.
first divide it is whether it is ketotic hypoglycemia or non-ketotic, because both the group have different further workup, investigation and further pathway. So if it is non-ketotic hypoglycemia, then you have to send only 3 sample. One is the serum insulin.
Yes.
Second is the urine for non-glucose reducing substance, that is for galactosemia. And third one is the IEM workup, and only rarer variety of IEM that has non-ketotic hypoglycemia is fatty acid oxidation defect. That is very, very rare to present at this age. Okay, so this is not in our mind. We have only 2 differential at this age. Okay, so narrow down your investigation based on your ketone ketone workup. Okay,
Yes.
and if it is ketotic hypoglycemia, then what is the first possibility to have ketotic hypoglycemia at this age?
Ketotic.
That you have given in your treatment part.
Ketotic hypoglycemia, ma'am, beta oxidate.
You have given hydrocortisone, na?
Yes,
So
ma'am.
if this
Cortisol
is
deficiency.
cortisol deficiency, it can cause ketotic hypoglycemia. Okay, so if it is ketotic hypoglycemia, then you have to send cortisol, growth hormone, thyroid function test that you can give send even without critical sample also, because MPHD can present with the ketotic hypoglycemia in neonatal age group. MPHD is multiple pituitary hormone deficiency. Okay, and then you have to send other metabolic workup. So other causes of ketotic hypoglycemia at this age especially is glycogen storage disease type 1. Though the onset is later, this is not too early. And they have other features also like organomegaly, chubby faces. They have like frequent hypoglycemia immediately after the meal, within 2 to 3 hours of meal. Okay. And they require very low amount of GDR. They are maintained, their sugar is maintained on 4 to 6 GDR. And as soon as you will shift the patient to full fit, they will develop the hypoglycemia. Okay, so this is the differential for ketotic hypoglycemia and other very rare form of IEM that can present with the ketotic hypoglycemia. So at this age, there are very few causes of hypoglycemia that you have to keep in mind. After ruling out normal causes like prematurity, IUGR, GDM, then like birth asphyxia, sepsis, like CNS infection, meningitis. So these are the first causes you have to keep in mind. Then second, whether ketotic, non-ketotic, then hyperinsulinism and galactosemia. If ketotic, then cortisol and growth hormone or deficiency or MPHD. Very rarely CH can present with the hypoglycemia, but CH is associated with other electrolyte abnormality like hyponatremia and hyperkalemia. So they are easy to pick up. And third thing is, and then glycogen storage disease type 1. Okay. So these are the very narrow differentials of hypoglycemia at this age. Okay. So now, can we conclude, madam, now?
Yes,
Riddhi,
yes.
Riddhi,
Yes, madam.
one question I wanted to raise. An
Yes, ma'am.
uncontrolled GDM, where the mother has not been on therapy, and the baby gets delivered classical GDM. My first lab sugar itself, not the glucometer. Glucometer was LLL. Lab sugar turns out to be 4. we really
Yes.
start with high GDR and control it. But how many? It really required very long time before
No,
we
ma'am.
could
So,
control.
no, ma'am. So mostly this IDM, infant of diabetic mother, longest like hyperinsulinemic hypoglycemia persist only up to 1 week.
So this was 1 week.
Yes,
It took us
so
1
they
week.
don't require the, I don't think diazoxide or
No, we didn't
unless
use.
until requirement of GDR is very, very high. Otherwise, they are maintained on GDR only, matlab higher level of GDR.
Yes, they get maintained, but I was just wondering how long does we had kept a cutoff of 1 week, and after that we thought we will investigate in case this is some rare together, some
Yes.
other. Mother
Yes.
was an uncontrolled, had a HbA1c of some 10.8 or 11.
Yes,
So
yes,
baby
yes.
definitely probably had all the reasons to remain hyperinsulinemic. So probably a week is a fair enough a time before we really think of
Week is enough time. Mostly they will recover within 4 to 5 days only.
Yeah, because GDR requirement was for longer time. Till because even enteral field could not counteract that hyperinsulinemic state.
Yes, madam. Yes.
Okay, thank you.
Thank you, Riddhi. I had one question. Can you share the details from where to procure the diazoxide and what will be the cost?
It's available now, Shwetal.
Yes,
The
madam.
company which is producing our Indoseed, and it is prostaglandin. The same company fellow is giving diazoxide.
No,
I think, ma'am, I have the number of representative which is easy providing diazoxide.
Because for
And
this
one of the
baby, I think I
medical
should
store
start.
nearby SSG is keeping diazoxide on hand. So you can procure it even at midnight also.
Okay, I'll check with Aeroy if they are keeping. And so for this baby, I think we should shift to a diazoxide.
Yeah, better. Because it may take time to recover. Definitely.
Yes. Okay, fine. So we'll do that. In that case, we need to like octreotide, we need to taper off, right?
Yes, madam. You have to taper off octreotide and then slowly introduce. Start with the very low dose, 5 mg per kg per day diazoxide in 2 to 3 divided dose. And then gradually, mostly around 8 to 10 mg per kg per day, they will be maintained.
Done.
Second
So
thing,
please
one
share
of
the number of the representative.
important side effect of octreotide, especially in IUGR and premature babies, NEC.
Yes,
So we are more worried for giving octreotide rather than diazoxide.
No, we'll taper off because previously it was not available. No, so we
now
we have a
Nowadays
free
it's
supply of
easily.
octreotide. It is from the hospital supply, and
Fine.
this diazoxide the patient has to purchase.
Yes.
So we started with the octreotide. Now we shift to diazoxide. Okay, okay. So thank you so much, Dr. Krunal. Are you there?
Yes,
Dr.
ma'am.
Krunal? Yes,
Yeah,
we can
ma'am.
wind up the
Very good
session.
case presentation.
Thank you, Riddhi. Divya has done this in less than half a day. Yesterday,
Wow.
I called you up at that same time. I asked Divya to present the case, and she has prepared very nicely.
No, it was very nicely presented, definitely.
And regarding hydrocod, I want to tell you that in the previous protocols we have, so we were waiting for the reports to turn up, and meanwhile we have started hydrocod. So as soon as the report of detectable insulin came up, we have shifted to octreotide. So that time was taken to receive the reports. But next time we will be very careful that we'll continue on the high GDR rather than starting hydrocod as a desperate decision.
Yes.
Shwetal, what has been happening is recently even in our one of the paper as a case which they presented. So I think still in our neonatal population, the protocol, most of the books, older ones, have been mentioning, and that's why it's continuing. I had a discussion because now.
But then this is a really great decision. Ki look at your cortisol and then give hydrocod.
Yes, that is the
because
protocol.
the body is producing too much amount of cortisol, then there is no need to give hydrocortisone from outside. Definitely.
Yes, perfectly.
It is not doing any good or extra job, rather it is doing harm. So that
do
is
you
the thing.
suggest a genetic analysis for this patient?
No, madam.
Because
this
it's an
is not-
SFD patient, a routine hyperinsulinemic hypoglycemia.
Because there
right?
are no features suggestive
No,
of
no
permanent
features.
variety.
The baby is absolutely no dysmorphic feature, nothing is there.
Nothing else, nothing else.
Okay. Thank you so much. Kunal?
Thank you, madam.
Yeah, ma'am, I'll wind up. Thank you so much, Dr. Riddhi Patel, for your elaborate discussions and your guidance and bringing out the new guidelines to aware and educate all the neonatologists so we can learn from and implement new strategies in the part of hypoglycemia, and we can stop using hydrocortisone, as madam has already told, Swetal madam, and we can rely on the reports of cortisol and then decide on the hydrocortisone and use diazoxide or octreotide as per the need of the patients.
Even
Uh,
if, sir, your report of cortisol is taking time to arrive, so
Mm.
you can do the urine cortisol, urine ketones. So this is very good bedside test
Yes.
that give you idea. If it is negative, it means this is non-ketotic hypoglycemia. You are not dealing with the cortisol deficiency.
Perfect decision.
Test is
Urine
to do
ketones comes
urine
immediately.
ketone, that you can do bedside. So even
Wonderful
blood
insight.
ketone can take time to arrive, but urine ketone you can do definitely.
Wonderful
Great.
insight. We'll be using this in our practice to implement better services to the patients. Thank you so much, and we'll wind up the session here. And thank you, Dr. Divya, for presenting case in such a short time and such a elaborate case presentation.
Thank you.
Thank you.
Thank you. Thank you, ma'am.
Thank you. And thank you, Clarinet, for the seamless online experience.
Ma'am, you are unmuted. So thank you so much, everyone. Thank you so much, ma'am. Am I audible? Uh, Thank you so very much for giving us this opportunity to host this session. So now with all your permission, I'm closing the session here for today. Thank you so much, everyone.